And start. Good afternoon, everybody, and welcome to Thrombosis Ireland patient session of VTE Dublin. We now have Dr. Kerstin DeWitt, who's going to talk to us about how to manage our personal risk of bleeding on an anticoagulant. Kerstin trained in internal emergency medicine in the UK and then in thrombosis medicine in Canada. She's a thrombosis and emergency physician in Canada and a researcher with Queen's University and McMaster University. Thank you so much, Kerstin, and welcome.
Thanks so much, Anne-Marie. This is an absolute pleasure to present here and a real honour. So this is the first time I have presented at your meeting, and it's important to me that the information I give you is appropriate for the questions and the things that you need to hear about. So I have prepared a slide deck, but I'm really happy to follow whatever conversation is important to you. So feel free to send Anne-Marie any questions that you have, and she's going to interrupt me as we go to address your questions. And I'm very, very happy to talk about anything to do with bleeding on anticoagulation and the risks of bleeding. So I'm actually, this is my first day in a new job in Queen's University, and I'm in my new office. And the Wi-Fi seems okay, but not as strong as it could be. So if it's okay, I'm going to turn my camera off for the presentation because I really want to be able to give the presentation all the way through without any problems with connections. And then towards the end, I'll turn the camera back on again so we can have a discussion and it's a little bit more interactive.
That's perfect. Thank you, Kerstin.
So as a thrombosis doctor, what I do is I'm always balancing the risks of blood clots, venous thromboembolism, and bleeding. So by prescribing an anticoagulant, we are essentially meddling with the clotting system of the body. But we know that for people who have a new deep vein thrombosis or pulmonary embolism or another type of venous thromboembolism, we know that the risks are way, way smaller than the benefits. So we know that starting an anticoagulant is the right thing to do. And now we actually know that if you are someone who's more prone to blood clots, it's actually more beneficial to continue you on a blood thinner rather than stop, because we know that will prevent further blood clots. So we're slowly understanding more and more about anticoagulants. But throughout the time a person takes an anticoagulant, their risks of bleeding very occasionally. So all the time, this changing balance between clotting and bleeding is something that you as a patient or a professional who works in anticoagulation and me and my colleagues as doctors have to balance. So the first question that I think is really important to address is, when we talk about bleeding, what do we mean by bleeding? And I apologize if this is really obvious to most of the people on the call today. I find when I work in the emergency department or if I work in the thrombosis clinic, when it comes to starting an anticoagulant, I always ask patients, have you ever had problems with bleeding? And usually the answer is no, but often when I probe a little bit further, when people think about bleeding, they think about cutting themselves and having a cut that won't stop bleeding, or some sort of external signs of bleeding. And I usually have to really explain in greater detail what I mean by bleeding. So I'm usually referring to bleeding from the gut, bleeding in the brain, the types of bleeding that's so bad that you need to be admitted to hospital for, or at the very least go to the emergency department for. So I'm going to start the presentation going over examples of ways which you could bleed, which would actually be really the things we're trying to avoid. And then we'll talk a little bit about how you can modify that risk personally. So why are we worried by bleeding? Well, everybody automatically knows bleeding is a bad thing. If you lose a lot of blood, particularly if you're losing it on a a longer time period, days, weeks, or months, then you become anemic. So that the concentration of red cells in your blood is less, and your blood's ability to carry oxygen to the tissues and nutrients is impaired. If you've been in a bad trauma, like a car accident, and you have some really bad injuries internally, you can lose a lot of blood very, very quickly. And when I'm working in the emergency department, we deal with those patients as well as people who've been bleeding slowly over time. And if you lose a lot of blood, particularly if you're losing it quickly, then you really are having life-threatening bleeding, because our body needs a certain volume of blood in order to maintain life. So that's the first problem with bleeding. The second issue that's bad about bleeding is sometimes the place that you have the bleeding is a problem. So the actual collection of blood within a space can cause some permanent damage. So the places that we always think about for local damage to tissue would be in the brain, because bleeding in the brain could essentially cause the symptoms of a stroke, which could be permanent, or in the spinal cord, which could actually cause paralysis. So you might, someone who has bleeding in the spinal cord, which is very unusual, but when it happens, they could end up paraplegic in a wheelchair. There's another place where bleeding, even small amounts, can cause damage, and that's in the adrenal glands, which sit right above your kidneys, and the adrenal glands produce the adrenaline and the get up and go hormones for the body, and without those hormones you really need daily replacement in order to survive, so you end up taking medication every day that your life depends on. So there's two kinds of bleeding, or problems with bleeding. One is losing a lot of blood, which can cause anemia, or it can cause collapse, fainting, and then if it was massive amounts of blood, you could cause someone to die. And the second kind of bleeding that's bad is bleeding in places like the brain and the spinal cord, which can cause local tissue damage, even though it might be tiny amounts of blood. So an example, what sort of symptoms would you worry about that mean you need to go and get help? Particularly go to the emergency or get immediate help from a doctor. If you're taking an anticoagulant and you have any symptoms of a stroke, so in the picture here, this is someone with a facial droop. Other symptoms of stroke would be new difficulty talking, or weakness of one side of the body, sometimes also associated with a heavy feeling or a numbness in parts of the body. So if you develop symptoms of a stroke, then you would definitely need to go to the emergency department. And the routine thing to do there would be a CT scan of the brain to be sure to see if there's signs of bleeding in the brain. It's very unusual to have this happen. Way less than, less than 0.2% of everybody in a year would ever have bleeding in the brain, but it's something that's really important to be aware about. The second, but much more common place to have bleeding when you take an anticoagulant is in the gut. And that looks like, if it's happening from the stomach or high up in the gut, then it will turn the stools to black tar. So people who take iron, and many of you I'm sure do, often have black stools. But when you have blood that's digested in the gastrointestinal tract, it is really, really jet black as black can be. Usually people who have bleeding that's so bad that gives you black, tarry stool might feel lightheaded, and they might have some pains in the stomach as well. And if that happened, then you should go to the emergency department to get checked out. And of course, sometimes when you bleed in the stomach, it makes you feel really queasy and then makes you vomit. And when you vomit blood, it often is not red, it's often black like coffee grounds or dark brown like coffee grounds. And that again is because the stomach acid digests the cells in the blood. It is quite possible to vomit bright red blood, and usually that means it comes from the esophagus above the stomach. And if you vomit it and it's brown coffee ground like, then that's a sign of bleeding from the stomach. Another really common place, particularly amongst men, usually older men, is to bleed in the urine. We call that hematuria. And this is a nice example of the color of the urine when you have blood in it. And you should really go to the emergency department if you have blood in your urine, partly because the natural tendency to the blood in the urine is to form a clot. And when you're peeing out a clot, sometimes a clot can get stuck, and that means it blocks you up and you can't pee anymore, and then the bladder gets bigger and bigger and it's very uncomfortable. So you definitely need to go to the emergency department to get that all sorted out. Very easy to sort out and help drain the bladder, but then the urologists would get involved and they would work out the right treatment for the blood in the urine to stop it. One last place where people can bleed is a potential space. It's a space which doesn't really contain very much in a normal person without bleeding. It's called the retroperitoneal space. So these are two views of a body. The one on the right shows someone who's been cut right down the middle, and the retroperitoneal space is a space right at the back in front of the spine, behind the gut, the colon, the stomach, and the picture on your left shows on a cross section of a body where the space lies. So it lies right behind all the gut. It contains things like big muscles, which sometimes you can get bleeding from. It also contains the aorta, which is the major blood vessel of the body. So we do sometimes get collections of blood in that space, and the reason why that's bad is mostly because the space can get really big when it's full of blood. So you can lose liters of blood into the retroperitoneal space. And I have an example for you. So this is a CT scan. It's a cross section of a body, and that huge big grey mass-like thing on your right-hand side of the slide, it's actually the patient's left, is a huge collection of blood. So you can see that like half of this person's abdomen is taken up with blood. And the main problem here is that they've lost a lot of blood, so they're going to be anemic and maybe their blood pressure is low. This is the much more common kind of bleeding. So I bet you this person has had some blood tests taken from their arm. So when you're on an anticoagulant, sometimes you just don't clot as well after a blood test or after having a cannula or a drip in your arm. And it can bruise. And usually the bruising will come on over days. The bruise towards the elbow is a little bit more blue, and the one towards the wrist is a little bit more yellow. So I would think maybe the one at the wrist is a little bit of an older bruise. The body is going to fix this. This isn't life-threatening and it's not going to harm your arm. It just looks really unsightly and it can be tender until your body's taking care of it. And that bruise is probably going to be there for 2 or 3 weeks. This is another kind of bleeding which often isn't serious but looks terrible. It's bleeding within a muscle. So I got this picture on the internet, and this is somebody who clearly had some sort of big impact to their thigh, to the outside of their thigh. And you can see 6 hours after the injury, there's like a what we call a superficial abrasion, so like a little bit of loss of skin. And then a day or so later, you can start to see bruising. And then maybe 2 or 3 days later, it's not till then that the bad bruising comes out. So most probably this man has intramuscular bleeding, so bleeding inside the muscles of the thigh. And the natural thing that the blood does is it migrates to the surface and it moves down the leg with gravity. So you can get a huge amount of bruising around the skin. So hopefully this is not a life-threatening or limb-threatening bleed, and the body will take care of this too, but it looks dreadful. It can really cause a lot of unsightly bruising. But give it a couple of months, his leg should be back to normal. Other common places. So unfortunately, some people are prone to nosebleeds, and when you're on an anticoagulant, the chance of having a nosebleed is just that much higher. You usually bleed in the nose from this little area, which is very vascular, with arteries and veins right at the top of the nose. You know, a short nosebleed with some pressure, maybe some ice over the nose, that's not a problem. If you can stop it in 5 or 10 minutes, it's a nuisance because getting blood in your clothes is a real pain. But sometimes the nosebleed just will not stop, and sometimes it can be torrential. So in those occasions, people do go to the emergency department, and in the emergency department, we can actually either cauterize, so try and just slightly burn the surface of where the bleeding is coming from to stop it. And although that can be difficult to do when there's a lot of bleeding going on, in which case we would pack the nose, so we would put some pressure inside the nose to stop the bleeding. And then the last thing that I think is worth mentioning, because people don't talk about it, is that in women who are still having menstrual periods, being on an anticoagulant can really be troublesome at the time of their normal menstrual period. It can really make menstruation much heavier. And often with that heavy bleeding, you can get pain. And the reason that's troublesome is, you know, these are people who work, and maybe they're so sick during those days that they can't even go to work. They can lose quite a lot of blood to the extent that over months they can become anemic. So it's something that's not talked about very often, but it can be a real nuisance. And we're going to go over a few options of ways to treat that. So I guess I'm sure everybody attending the meeting already knows this, and I don't think you would be attending it otherwise, but anticoagulation medication is different from other medicine because it has consequences if you don't take it as prescribed. So it's really important that you're deliberate and thoughtful about how you're taking your medications. So if the doctor has prescribed your medication to be taken twice a day, then absolutely it should be twice a day, and it should be ideally 12 hours apart. That's probably more important than other medicines because we have a slightly higher risk with anticoagulation, and that is the bleeding risk. And we want to avoid you having to go to the emergency department, which everyone hates. It's a waste of time, it's unpleasant, busy, noisy, and you often have to wait for hours. So even if it's bleeding that can be fixed in the emergency department, it's better not to be in that position to have to go. So I've had many examples in clinic of people who I have told very carefully about their dosing, and I've given them printouts that also go over the dosing of their medicines. And then when they come back, you know, one example is for Rivaroxaban, we start morning and night 15 milligrams a day. And then after 3 weeks, we change to 20 milligrams once a day. And I have very occasionally had people continue their 20 milligrams twice a day, which is a real threat to their health because the risk of bleeding is much higher because they're having more anticoagulant in their body than they need. The equivalent with warfarin would be maybe not getting your INR tested or just failing to turn up for your appointment and letting that go. And then when you have your INR tested, it's sky high. So from my point of view, from the thrombosis clinic point of view, I think you really need a team of support when you're taking an anticoagulant. And everyone's team will be slightly different, but your team should definitely include the doctor who's prescribing the anticoagulant. So I really like it if there's one doctor prescribing, not more than one. If I'm in thrombosis clinic, I like to give my patients the prescriptions, and if they say, oh, my family doctor refilled it, I always tell them, no, please don't ever do that. Just get your pharmacy to fax us and we will refill it because we know the right dose, and it's very easy. You know, we might be doing some slightly more complicated dosing regimes for different reasons, and it's very easy for someone else just to assume the dose and prescribe the wrong dose. So always have one doctor who is responsible for your prescription. and have a way of either contacting that doctor or the clinic who's managing it or the specialist nurse, but have a phone number that you can call so that if you ever had bleeding problems, they can tell you, oh, you know, that's fine, you don't need to worry about that, or maybe just miss your dose tomorrow and then call back in the next day and we'll review how you're going. That's worthwhile because you're getting specialist advice and it avoids that horrible trip to the emergency department. Your pharmacy or your chemist is also someone in your team because they're going to look at the interactions between your medications. Particularly people on the newer anticoagulants, there are a few interactions that many doctors don't think about. So the chemist or the pharmacist is going to check those interactions. So they're definitely on your team. And then there are other people who may or may not be part of the support team. We have lots of older adults who are taking anticoagulants, and really the only safe way for me to prescribe is often for their pharmacy to use a blister packet or a dosette packet. So the tablets are divided up into little individual packets for morning, afternoon, evening, and that's really for them the safest way for them to take their medication. So we also have people who take Warfarin who are elderly, maybe live on their own, but they have an amazing family, maybe a daughter, son, husband, wife, who helps supervise their medication to check they get on the right dose. So no one can do this solely on their own, and everyone's team looks different, but you need a team so you have a plan if things aren't going right. So I know you've just had a wonderful talk about anticoagulation, so I'm not going to bore everybody with the differences, but on a much sort of larger scale, there are a couple of bleeding differences between the DOACs, the direct oral anticoagulants, which are these guys, so Edoxaban, Apixaban, Rivaroxaban, and Dabigatran, and Warfarin. So these anticoagulants, easier to take because they're a fixed dose, and you don't need so many regular blood tests. But we know that these drugs have a higher rate of bleeding in certain places in the body. Because these drugs, generally speaking, are active when you swallow them, if you were developing a stomach ulcer and you didn't know it, if the drug sits on top of that stomach ulcer, it's an anticoagulant and it will promote any inflamed tissue to start bleeding. Same as if somebody had a bowel cancer they didn't know about. So let's say there was a small tumor in the colon, these drugs will bathe the colon and they might bathe over the tumor surface and that might cause some bleeding from the colon. And in fact, that's actually a way of, we find some people are diagnosed with new colon cancer after they start these drugs because they induce bleeding. So that's just one thing to be aware of. There's a bit more bleeding from the gut on the whole compared to warfarin, and that's because these are active drugs when you swallow them. There's a little bit more bleeding from noses and in the urine. So if you have issues with the bladder or prostate, there's a slightly higher risk of bleeding there. But you know what, bleeding from the nose or urine, that's easily taken care of. And generally speaking, bleeding in the gut is easily taken care of too, although it does often mean coming into hospital and having an endoscopy. What about warfarin? So warfarin isn't active when you swallow it. It has to go into the body, it has to act on the liver and reduce synthesis or reduce production of the proteins which help your blood clot. So the warfarin tablet you take today is not really going to have an effect for 2 days. So we don't see that same effect with the gut when you swallow it. Although you can have bleeding from the gut, it's a little less likely. But the thing about warfarin is we see just slightly more bleeding in the brain. Bleeding in the brain is very, very unusual. It's very unusual in fit and healthy people, and we see it more often in people who are very elderly, frail, maybe have some strokes, or it also sometimes people who have brain tumors. And of course, we have this great support network. So Thrombosis Ireland has some great helpful printouts about the medications. We have Thrombosis Canada, where I work. We have the same. So you can go onto these websites, download and print their information sheets about the medications, which is so helpful. When do people have bleeding? So this is a graph actually from people in the Netherlands who were started on anticoagulants for atrial fibrillation, for stroke prevention. So along the bottom axis is the number of years over time, and on the y-axis it shows you what percentage of all these people had bleeding problems. And the thing that's actually probably the most important is you see right when you first start your blood thinner, that's actually the highest risk time for bleeding in the first 3 months, because the slope goes up really pretty sharply. So there are more people developing new bleeding problems when they first start blood thinners. But you can see that all the blood thinners have bleeding problems. The second time that there's a slightly higher risk of bleeding problems is when you're sick. So people who get really sick, who become bedbound or hospitalized, have a higher risk of developing bleeding problems. So it's doubly important for you to check in with your doctor. So if you're on Warfarin, to get your INR checked. If you're on a DOAC, you take it as prescribed, but maybe check in with your doctor, and if there's any concerns, you come into the hospital. Your bleeding risk is going to change. So when you're feeling healthy and there are no other problems with your health and your life, on the whole, your bleeding risk is going to be very low. But it's going to change over the years if you take a blood thinner. So the first thing which really puts people at risk of bleeding is having had some serious bleeding very recently. So let's say you are the gentleman we saw who had, I don't know, maybe fallen off his bicycle, who had that big intramuscular hematoma in his thigh. Well, if he had held his anticoagulant on the advice of his doctor, then the highest risk time for him to have more bleeding is when he starts again. So that's why it's super important that if you have bleeding, you have your doctor who prescribed your anticoagulant involved, and they can supervise the dose that you start at, because sometimes we start with a DOAC, a slightly lower dose, for a week or so just to test the water. So having had recent bleeding is the highest risk time for having more bleeding. If you have any kidney impairment, so if your kidneys are not 100%, there is an association with having bleeding problems. And when we calculate how well your kidneys are working, actually we use an equation which involves your weight. So if you're having weight loss, sometimes when we plug that into the equation, that can mean that your kidney function is not as good as it used to be. And I know that's a little bit complicated, but the equation uses a creatinine in the blood, which is a blood level that relates to kidney function, and we use weight in the equation to calculate the creatinine clearance. So if you have kidney issues, it's important to have blood tests fairly regularly, at least every 6 months. And particularly in older people who have kidney function problems, if they have weight loss, then it's important to check in with their doctor so that kidney level can be recalculated. Everyone knows this. If you take a blood thinner and anticoagulant, we want to limit your exposure to other medications that can also cause bleeding, and the classical one is aspirin. Some people have a very strong indication for both aspirin and an anticoagulant, and that's fine. So strong indications would be recent strokes, a recent stent in the heart, but in that case, the doctor prescribing your anticoagulant should know that you're also taking aspirin. And if possible, we will limit the number of time, the length of time that you're taking both of those. There are other drugs like aspirin, such as clopidogrel, which is also called Plavix, or ticagrelor, which is Brilinta, and cardiologists do prescribe those, and we want to be really careful to limit the number of time that you're on both that drug and an anticoagulant. Same goes for ibuprofen, Brufen, anticoagulants, or anti-inflammatories, and naproxen, which is also an anti-inflammatory. So we want to limit using both of those together. If you've had a blood test, and one of the blood tests is the full blood count, so they're measuring your hemoglobin, and your doctor tells you that you're becoming anemic. When you're taking a blood thinner, the first thing we think about is there any chance that you have blood loss that you don't know about? So if anyone comments that you have anemia or anemia that is getting worse, then check in with the doctor who's prescribing your anticoagulant, just so they can go through a little, examination checklist in their head and see, do you need some tests to check for bleeding? Unfortunately, as we age, bleeding risks get higher. So that's not something we can modify, but it's something to be important to remember. So when we're in our 80s or 90s, our risk of having serious bleeding is just going to be higher. And that's just an example of how, as we age, or as we go through life, if you're taking an anticoagulant, your bleeding risk will change. And last of all, having a diagnosis of cancer, and particularly cancer that's undergoing treatment, maybe with chemotherapy or surgery, the risk of bleeding is higher too. So there are many different reasons for that, but the end result is there's just a higher risk of bleeding. Unfortunately, people with cancer have a higher risk of clotting as well, so we really do prescribe anticoagulants for people with cancer, but we just are especially careful to monitor them. Same with as people age, the older you are, the higher your risk of clotting. So just because you're older doesn't mean to say you shouldn't be on a blood thinner, but we just need to be very carefully monitoring the anticoagulant. So just to finish off, an example. So we have a patient who's just been diagnosed with a deep vein thrombosis. The leg's swollen, looks painful, looks horrible in the picture. They were diagnosed in clinic, and they come into the emergency department, and there's blood in the urine. So this is a typical story. This might be somebody who has a history, say, of prostate cancer or bladder cancer. So there are things we can do to get rid of the blood in the urine. So the first thing is we would hold off on the anticoagulant, and we might admit the person. And then if they were on, say, a DOAC, I would look at changing over to a different kind of anticoagulant, maybe even an injectable low molecular weight heparin, because there's a lower risk of blood in the urine with that medication. So just to say that we can treat this, but it does need careful specialist management. This patient would get back on anticoagulation probably the next day, and we would maybe increase the dose over a matter of days, and they would probably do very well and there'd be no issues, but it does need managed. This is a typical classical case in the emergency department. This is a man who's 77. He's come in because he's fallen at home, but actually when I see him in the emergency department, he's got lots of medical conditions, lung disease, heart disease. He's on an anticoagulant for pulmonary embolism in the past. He also has kidney disease, so he's got an added risk for bleeding. And he's on a 20 milligram dose of Rivaroxaban, and he takes aspirin. And when I look at him, he looks very frail and he's very bruised. And people who are abnormally head to toe bruised worry me, because I worry that they're at risk of bleeding inside, because the bruising is just what we see on the outside. And this is a typical case of somebody who's got multiple risks for bleeding, and I would want to really evaluate him carefully. I would want to check his kidney function, so I need to take a blood test for that. I want to check his hemoglobin to see, is he anemic, as a sign could he be bleeding. He's on the more standard dose of Rivaroxaban, and maybe for his kidney disease he might be more appropriate for a lower dose. And I would want to check in why he's taking aspirin, because maybe he doesn't need to be on aspirin now. So we can easily do these checks and optimize blood thinners, but you need to see a doctor for someone to be able to do that. Because this man maybe started his Rivaroxaban when he had no kidney disease, when he wasn't on aspirin, when he was much healthier. So I'm sorry, I've gone a little bit long, but hopefully we'll have some time for questions. So just to finish off, an example. So we have a patient who's just been diagnosed with a deep vein thrombosis. The leg's swollen, looks painful, looks horrible in the picture. The patient who's got lots of medical conditions, lung disease, heart disease. He's on an anticoagulant for pulmonary embolism in the past. He also has kidney disease, so he's got an added risk for bleeding. To summarise, bleeding is actually very uncommon. So I apologise because I don't want to scare everyone by the presentation. I'm just showing you the places where bleeding can happen, but overall bleeding is uncommon, and by far and away almost everyone in anticoagulant has no bleeding problems. You always need to check in with the doctor who's prescribing your anticoagulant and keep the prescription to one doctor. Just be mindful of how you're taking your anticoagulant and be sure you're taking it in the way it was prescribed to be taken, and have a plan for somebody to check in with, ideally a telephone call if possible, if you're worried about bleeding, because sometimes it just takes, 2 or 3 words on the phone to ease your mind or to change the plan of action. So I'm going to put my camera on, and I am very happy if there are any questions that you want to discuss.
That's brilliant. Thank you very much, Kerstin. I suppose, can I just clarify, if you do have a bleed, the plan is to immediately get it checked by your doctor?
Yes, and bleeding comes in all shapes and sizes, and I think the reason particularly I put the slide about younger women with heavy menstrual periods is that's something they have to deal with every single month, and if they were checking in with the doctor every month, they'd have no life. So bleeding just comes in different ways to different people.
Yes.
And the really urgent emergency times to get checked would be if you have signs of a stroke, if you have black tarry stools or even bright red blood in the stools, if you're feeling dizzy, abdominal pains, then I would say just go to the emergency department.
Okay, thank you. Did you say immobility increases the risk of bleeding, like by virtue of being in hospital? Does that increase your risk, or did I pick you up wrong?
Yeah, so there are lots of reasons why you can have a higher risk of bleeding when you become sick for other reasons. One reason is sometimes people develop kidney impairment if they have an infection or they have something else going on, and particularly with the DOAC medications, if you have sudden kidney impairment, that can let the medication accumulate in your body, and that sometimes can cause unwanted bleeding. So the relationship isn't 100% clear. Definitely on warfarin, when you become sick, it's quite a common thing to see that the INR goes really high, just because maybe you're not eating or drinking, and maybe you missed an INR, or maybe you have some new medications that are interacting to help treat whatever's wrong. But it's just a slightly higher risk time.
Okay, so with an INR of 3 to 4, how long would it roughly take to control bleeding from the cut of a knife, let's say, when should you seek medical help? Do you have an idea?
So if it's a knife cut, I would say get medical help for the knife cut if you would normally get medical help. So if the skin wound is gaping open and is going to need sutures, or if you can see a tendon, or if you can't use your hand, you go to the emergency, because that needs stitched closed anyway, whether you're on warfarin. I wouldn't worry if your INR is 3 or 4 and you've cut yourself. If it's like a cut that doesn't need medical attention, if you weren't taking warfarin, what I would do is I'd grab a tea towel that you don't ever want to use again, some old tea towel, wrap your hand or whatever part of the body you got the cut, and you press, and sometimes you have to press for an hour, but only pressure will stop that bleeding. So you just have to press, because we see people in the emergency department who maybe aren't even on blood thinners and they've cut their hand and they say, I couldn't get the bleeding to stop, and all I do is press. I just press for longer. So if it's a cut that doesn't need a stitch, pressure will stop the bleeding. You just need longer pressure.
Okay. Do you advocate for wearing alert bracelets?
That's a great question, actually. And I've noticed really a variation in practice. Because I work in the emergency department as well as in the thrombosis clinic, I actually tell my patients they don't need to wear one, but it's a choice and it's up to you. And the reason that I say that is, if you come into the hospital with bleeding problems or in an accident or something, then 98% of the times that'll happen, you're going to be awake and you can tell people that you take a blood thinner. So the only time that it would be necessary is if you were unconscious. So probably a really serious accident, a head injury, you know, really bad, which is unlikely to happen but is possible. The second issue is that now we have fairly robust electronic medical records. So in the emergency department, we can look at your hospital records to see what medications, you know, you were taking the last time you were seen in clinic or whenever the last interaction was with the hospital. It varies hospital to hospital and country to country as to how many other hospitals in the area information you can access. But you would pretty much have to be both unconscious and go to a hospital where you've never been to before that has no access to your records for them not to know you're on a blood thinner. Because the first thing you do with someone who's unconscious is you look at their medical records. You know, 20 years ago, when I started in emergency medicine, I had to order the whole chart from the department called medical records, and they would deliver this paper chart, you know, maybe the next day. But now it's all electronic, so it's your choice. And if you feel better wearing a medical alert, by all means. But it's probably unlikely it will need to be used. Yeah.
Okay, thank you. I think maybe in an elderly person that maybe has some Alzheimer's or something, that it mightn't be a bad idea to have, because particularly now when nobody else can go in with them, and they probably can't answer their questions, it might be a good idea. But I think most of us are fine without it, unless you want a little reminder if you're going into the pharmacy to get other drugs, reminding yourself, well, I'm on an anticoagulant, just to let you know. You know, I think it's probably a personal choice, isn't it, really? It
is, and actually you raise the excellent point that you're so right. In this pandemic time, where in the emergency department we're only allowed to see the patient and we can't have the family there, it's so hard with people with cognitive impairment, and so many people have cognitive impairment. The most helpful thing is if you know, if it's your mother or father or someone who's going to the emergency department, if there's any chance to take their blister packet in, if they have their blister packet or Dosette packet, I'm not sure what the correct term is.
Prescription, something, their prescription.
Yeah. If there's, like, if they have their medications dispensed in those little plastic bubbles, if they can take that in with them, that is so helpful.
And I suppose I'll just finish, probably a reminder, a lot of people now are being changed, particularly in this time of COVID, are being changed from Warfarin to a DOAC if they're suitable. And it's just a reminder to everybody that you don't take both, that it's not a phased changeover, that if you're moved to a DOAC that you don't continue to take your Warfarin. Would you agree?
Yeah, I've seen this so many times too. Sometimes it's happened at hospital discharge, maybe with an older adult who may or may not have cognitive impairment, but so we often do switch between even injectable low molecular weight heparin and DOACs in and around times of bleeding or illness. And I have seen people who've come in with bleeding and they were taking both, say, Rivaroxaban and Fragment or something like that, yes. Which is just awful. I mean, it feels like such a failure of our health system that ever was able to happen. Yeah. But I think it really speaks to the fact that when you take an anticoagulant, you have to be the owner of your medications and really have an in-depth understanding of the importance and the regime that you're supposed to be on. Yeah.
Absolutely. I think that's a big thing, and it's a lot to put on somebody because they're complicated drugs. It's a lot to put on a patient, but I think really if it's even just ownership of ensuring that you're checked and that you check in regularly. We have we have a little video, a DOAC video. It's a card, and you just play it from your phone with the photograph, the camera part of your phone, and it explains all about how to take a DOAC, what you're on, like a total understanding. So if anybody listening would like one of those cards so they can play the video and have it handy, they're very welcome. And if you know anybody on a DOAC, advise them that maybe that they need to educate themselves on what they're taking and what they need to do to protect themselves.
Yeah.
Thank you, Kerstin. That's just fantastic. It was really, really informative, and we really appreciate your input. It was brilliant. Thank you.
Thank you. Real
honor.
honor.
Stay on the line there for a second.
Okay. Thank you.